Okay. When was the last time you actually sent someone to a liver transplant?
It's been a while.
Yeah, no, I think the liver transplant future in TTR is probably pretty much over, actually. I think these drugs have really changed that. And it is interesting because, you know, they also brought up Domino livers. That is, they could take livers from the patients with TTR and give them to other people with end-stage liver disease. And so I think that practice for TTR is probably pretty much over.
And the process of Domino transplantation, is that safe? Does it confer disease in the recipient?
It absolutely does. But the thinking has been that these are people who will probably die from their liver disease, and so they don't have a lot of choices. So if they take a liver from somebody with TTR amyloid, at some point down the road, they will also develop their own neuropathy if they live long enough, but that probably will be delayed. But in my own institution last week, we had a grand rounds on a patient who had end-stage liver disease, got a Domino liver transplant 5 years later, developed a very progressive neuropathy and died within 5 years of developing it from TTR amyloid from his Domino liver.
So I think that's very illustrative, and I'm glad you brought that up. The original thinking behind the Domino transplant process was that if it took 50 to 55 years for the first person, the original owner of the liver, to get familial amyloid disease manifestations, the same was going to be true of the recipient, so that they would effectively be protected from ever getting disease. But what we now know horrifically is that the recipient is the recipient of an accelerated disease process, and that actually is an issue that Akshay sort of touched on. We don't understand the influences in TTR process. You're born with the abnormal protein. Why is it a middle age onset of disease? And what are the things that either retard or accelerate the disease process? And those are all things we don't know. But I certainly echo your thoughts about orthotopic liver transplants. There's one population in the world, and that's the V30M population, particularly with early onset in Portugal, that has been well treated with that early intervention. But recent data from Teresa Coelho shows that tafamidis in low dose has actually better survival than the aggregate population who's undergone liver transplantation. So I pretty firmly agree with you that the time of liver transplant is past, and that when people consider it now, particularly in those who have significant amyloid deposition in the heart or nerves at the time of transplantation, they are probably misguided, because there will be progressive disease even with a successful liver transplant. And that deposition is going to be wild-type TTR on top of the variant matrix that's already present. So it's a little bit off topic, but liver transplants may not be part of the process now, but what about some of these patients who have polyneuropathy, or maybe they have a variant that is heart-specific? Do you consider them for liver transplant? And Akshay, I'm talking to you.
Yeah. So I think it's a moving target. I think that we have certainly been concerned about isolated cardiac transplantation until recently in patients with familial variants of amyloid that affect the heart, because there has been the concern that the donor heart will ultimately develop the same process. I think given this long gestation period between the development of clinically relevant amyloid cardiomyopathy and initial exposure to the variant protein, the thought has been that maybe you could get away with isolated heart transplantation in the same way that you talked about, but there's been some reluctance to think about isolated heart and think more about heart-liver as an approach in these patients. I think that the ability to delay or stop deposition of amyloid in the donor organ really opens up a new window of opportunity, because now if you have patients who present with predominantly cardiac involvement by amyloid in the setting of a familial inherited transthyretin protein variant, then in that circumstance now the donor heart might be able to be insulated from development of clinically relevant disease. And so I think the potential for heart transplantation is expanded in this modern era of novel therapeutics.
Yeah, I think you make a very interesting point that the cardiac transplant programs have been fairly myopic in viewing the issue as whether or not there would be disease recurrence in the allograft. But at the same time, the rest of the body is still being exposed to variant protein. And we have experience in following up people who have had isolated heart transplants, preserving the criminal liver in which the patients have progressed with extra cardiac disease, be it in the lungs or nerves or both, which ends up being just as devastating. So I agree absolutely.